So I'm Anna. I'm one of the first year urology residents, and I'm going to talk about radical cystectomy in women. My learning objectives are to identify the differences in outcomes of radical cystectomy in women and men, and then to discuss both urinary diversion options in women as well as the role of organ-sparing cystectomy. Just a bit of background statistics. So the incidence of bladder cancer in women is about 4 times lower than in men. However, if a woman is diagnosed with bladder cancer, there's a 20% higher likelihood of death, and women have worse outcomes after radical cystectomy. There are several theories for these worse outcomes. They include access to healthcare, delay in treatment, as well as both cancer-specific factors and host biology. In terms of access to healthcare, there have been several studies that have showed that women are less likely to receive a referral for gross hematuria. They're less likely to be worked up fully for microscopic hematuria. And the majority of women actually have received at least one course of antibiotics to treat a urinary tract infection before they receive a diagnosis of bladder cancer. Even after a diagnosis, there's a lag of re-referral for recurrence of symptoms. Women also generally have worse disease at time of presentation. So here you can see a study done in 2015, which compares outcomes in males and females. And in terms of both T stage and N stage, women have statistically or significantly higher disease at time of presentation. They also have higher rates of hydronephrosis. In 2014, a study was done which matched 414 women with 414 men based on cancer-specific factors, so stage, grade, nodal disease, etc. And they found that if men and women were matched based on these factors, that the difference in recurrence-free, cancer-specific, and overall survival actually disappears. So this again supports the idea that cancer-specific factors are involved. A large study of the Netherlands Cancer Registry of almost 25,000 patients again found that women had worse overall survival than men, as you can see in this graph here. However, when they looked at sex-specific mortality ratio over time, on this side here, you can see that women in red were significantly worse off for the first 2 years, but then they kind of became equivalent to men after the first 2-year period. A second study was done of the Norway Cancer Registry, also a large cohort of patients, which showed the same thing, so that worse outcomes were limited to the first 2 years after diagnosis. And so both of these studies hypothesize that this is likely due to the fact that women present with worse disease. In terms of host biology, there's several involved factors. So one of them is that hormones are involved. So women who have undergone menopause or have had an oophorectomy are at higher risk of bladder cancer, while things like older menarche, increased parity, and being on estrogen progestin combination therapy are actually protective. So the thought here is that the estrogen receptor alpha may suppress initiation of bladder cancer, while estrogen receptor beta promotes progression, which would explain why women have a lower incidence but higher mortality when they are diagnosed with bladder cancer. Androgens are also thought to be involved after studies of mice have showed that castration as well as androgen receptor gene knockout are actually protective against bladder cancer. A different thought or a different theory is that there's differences in metabolic detoxification between men and women. So one example of this is that there's a study done looking at this enzyme GST in females, and it showed that women who have an inactive version of GST are smokers are more likely to develop bladder cancer, because GST is responsible for detoxifying the carcinogens related to smoking. And since GST is inactive at different rates between males and females, this might be at least partially responsible for the differences seen. And then there's also anatomical differences between males and females. So just based on the definition of T4A cancer for men, this means invasion into the prostate and seminal vesicles, while for women, this means invasion into the vagina, cervix, and uterus. And so the thought may be that these actually aren't completely equivalent, and that by the time the tumor has invaded into the uterus, it's actually more aggressive than just invasion into the prostate, and this may account for some of the differences seen. And then several animal models have been done which have shown anatomical differences, such as differences in mucosal blood flow, angiolymphatic spread of cancer cells, and bladder wall thickness, each of which may promote easier spread of cancer cells in females compared to males. In terms of radical cystectomy specifically, again, there are worse both short and long-term outcomes in women. So in terms of short-term outcomes, increased readmission rates, increased transfusion rates, longer OR times, and then long-term, again, there's decreased overall and recurrence-free survival. There's differences in urinary diversion between men and females. So females are much more likely to receive an incontinent urinary diversion than a continent when compared to males. And if women do actually receive a continent urinary diversion, compared to their male counterpoints, it's more likely to be a continent cutaneous reservoir than a neobladder. And finally, women are less likely to be counseled about sexual dysfunction. So looking back on kind of a historical perspective of urinary diversion, initially when neobladders were first being used, it was thought that they were only for men, not an option for women. And this was because the thought was that continence was actually dependent on the bladder neck in women. And therefore, if they underwent a cystectomy, it would be impossible for a female to be continent. Additionally, because of the shorter urethra, it was thought that there was a shorter or lower margin of safety, and that it was not oncologically feasible for women to undergo or to have the urethra spared. In 1990, a group examined cystectomy patients of 22 females, and they found that out of these 22 females, 8 of them had urethral involvement, and therefore concluded that this justified routine urethrectomy during cystectomy in female patients. This was challenged in the mid to late 1900s. This group here, Kolesi, in 1998, looked at 9 fetal specimens and 4 adult cadavers and found actually the sphincter in females is not right at the bladder neck. Instead, the majority of the smooth and striated sphincter muscle is actually in the middle and caudal 2/3 of the urethra, and therefore technically they could be continent after or with a neobladder. Additionally, the nerve plexus fibers were located so that careful dissection of the bladder neck and proximal urethra could actually spare the nerve fibers, and therefore they suggested that a neobladder may actually be an option for females. Stein in 1997 published one of the first case series looking at neobladders in females and their continence rates. So they had 34 patients and found that their daytime continence rate was 85%, while nighttime continence was 82%, and only 15% actually needed intermittent self-catheterization. Of these, 2 patients only catheterized twice a day because they had high residuals, while the other 3 were fully dependent on catheterization. And they found that 100% of their patients were actually satisfied with the overall results of undergoing a neobladder, and so suggested that continence is actually acceptable in females after a neobladder. In terms of looking at the oncological safety, these 2 studies here, so a total of about 400 patients, looked at cystectomy specimens in females, and they found that if there was no bladder cancer at the bladder neck, there was also no bladder cancer at the urethra, and so they suggested that a neobladder might be safe in women with no bladder neck involvement. Stein took this a little bit further with their series in 1998 of 71 patients, where they actually did intraoperative frozen sections of the distal surgical margin to determine whether or not a neobladder might be safe. And they found that unless the intraoperative frozen section was positive, there was no urethral involvement, and therefore concluded that an intraoperative frozen section can accurately and reliably evaluate the proximal urethra. And then finally, there is a systematic review done in 2006 just looking at overall the rates of urethral tumor involvement in women undergoing radical cystectomy. And the results are shown here, but overall, only about 12.4% of women had urethral involvement. And so they essentially concluded that in many women, sparing the urethra would be reasonable. Looking at actual clinical data, the same systematic review also looked at the rate of urethral recurrence in females who did receive a neobladder and found that this was between 0 to 1.4%, so quite low, although the data was sparse. When you compare this to urethral recurrence rates of men, which they quoted as around 6%, it seems like an acceptable risk. And then in 2009, Stein did a retrospective review of 201 patients, where 120 received a neobladder and 81 received a cutaneous diversion. And then in their series, the patients who underwent neobladder usually had less severe disease. However, even when they stratified by disease, so organ confined versus extravesical versus lymph node positive, they found that overall survival and recurrence-free survival was not different between groups, with the exception of extravesical overall survival. And this was actually better for the neobladder patient than for conventional cystectomy patients. It is important to keep in mind, though, that for these studies, there is a large a bias towards patients who are younger and healthier receiving a neobladder. So from this these studies, it seems that a neobladder is a reasonable urinary diversion option for females, and so the thought is that ileal conduit, continent cutaneous diversion, and neobladder should all be discussed with the female undergoing radical cystectomy, or at least considered. Ileal conduit obviously is the most commonly used urinary diversion. It's technically simpler with a shorter operative time and an easier early recovery period. So you don't have to deal with multiple Foley catheters or cystograms or any of that in the recovery period. However, there are disadvantages. Obviously, it's incontinent, so patients will require an external appliance lifelong, which can be associated with costs as well as impaired body images, and then complications like skin breakdown or leakage. There's also complications related specifically to the stoma. So peristomal hernia are relatively common, and then stomal strictures can occur as well. In 2008, a single institution review of 281 cystectomy compared complication rates between ileal conduits, Indiana pouches, and neobladders. And they found that early complications, shown here, were not different between the groups. And the only risk factor for having a major early complication in their multivariable analysis was having a high ASA score. In terms of late complications, the pale yellow here shows patients with no late complications, and you can see there's more patients with no complications in the ileal conduit group. However, when they looked at exactly which complications were involved, this was accounted for completely by uncomplicated urinary tract infections, which actually made up 1/3 of all late complications. And then looking at the orange at the top, which represents the major late complications, there were no differences between groups. A second similar study was published in 2017, looking at 322 patients, and they again found that there were no differences in complication rates between ileal conduit and neobladder and continent cutaneous diversion. So in terms of continent cutaneous diversion, obvious advantages are that it's continent. It also has a decreased rate of incontinence when compared to a neobladder, but it requires lifelong catheterization, and there's risks of difficult catheterization, stomal stenosis, incontinence, and pouch stones. When looking directly at the actual rates of continence in continent cutaneous diversion, the same two studies that looked at complications examined this as well. And you can see here that for yellow, so daytime continence, Indiana pouch had a rate of 96%, while for nighttime continence, the rate was 74%. Similar rates were found by the second study of 322 patients with a daytime continence rate of 96% and a nighttime continence rate of 89%. Neobladder is advantageous because, again, it's continent, but it also allows patients to void for their urethra, which conserves body image. Disadvantages are a risk of hypercontinence, as well as both day and nighttime incontinence. There can be urethral recurrences of cancer because you're not doing a urethrectomy. And then specific to females, patients can develop a neobladder vaginal fistula. A systematic review in 2017 tried to quantify the rates of continence following a neobladder in females, and they found that the data was poor. They collected 34 studies, which were quite heterogeneous and usually had small sample sizes. So the largest study was 177 patients. However, they concluded that the daytime incontinence and nighttime incontinence rates were about 20%, with hypercontinence present in about 15% of patients, which they concluded was a relatively acceptable number. And then interestingly, there's been several studies that look at the quality of life in patients, comparing neobladder, ileal conduit, and then also cutaneous continent diversion. And all of these have shown that there's no real difference in health-related quality of life between the groups, although it is important to keep in mind that there's quite a bit of bias because these are all done via surveys, and most patients will support their choice, so be happy with what they chose. In 2002, Stein's group tried to put together a list of indications for neobladders in women, and the two important points that they highlighted was that it's super important for females to have an intact external sphincter with good innervation to the sphincter so that a patient may be continent following a neobladder. And in order to have this occur, they recommend choosing patients that have good preoperative continence, as well as patients who are able to and willing to do clean intermittent catheterization if necessary. Additionally, it's important not to compromise oncological safety, and so only patients who have negative intraoperative frozen sections of the proximal urethra should be included, and only patients who will be compliant with long-term follow-up for urethral surveillance should be included. The last thing here that we haven't talked about yet is sexual dysfunction in females after radical cystectomy. So a study by Gupta in 2020 surveyed 140 urologists to look at practice patterns. And as you can see in this graph here, where yellow is female patients and this blue is male patients, in terms of counseling about baseline sexual dysfunction, 60% of female patients do not receive counseling on baseline sexual function, which is significantly higher than their male counterpoints. And then in terms of risk of postoperative dysfunction, again, here females are significantly less likely to receive counseling than their male counterpoints. They also receive less counseling on the potential for a nerve-sparing approach. And this is important because there have been several studies that link lack of education to sexual dysfunction. Additionally, it's been shown that almost 50% of patients really would like more information about sexual dysfunction preoperatively. Zaran in 2016 did a systematic review trying to quantify exactly what sexual dysfunction looks like in females, and found that in 11 studies and 361 women, the rate of postoperative sexual dysfunction after a radical cystectomy was 59%. In this table here, you can see that decreased desire was most common at 49%, with orgasm disorders being second most common at 39%. And then in 2022, another systematic review was published, which suggested that the most likely cause of decreased sexual function in women after radical cystectomy was damage to genital organs, the neurovascular bundles, and devascularization of the clitoris. And this can be exacerbated by estrogen deprivation if the ovaries are removed, as well as decreased libido when the ovaries are removed. And therefore, it's important to understand the anatomy involved in the female sexual response. So just in brief, the pelvic nerve plexus is super important because it provides both autonomic and sensory innervation to the vagina, uterus, and cervix. This means that the pelvic nerve plexus is responsible for responding to arousal and genital stimulation by increasing blood flow to the erectile tissues. So here the corpora cavernosum and the bulb of the vestibule, which runs right by the urethra. And this causes protrusion of the clitoris and increased sensitivity. The pelvic nerves are also responsible for increasing blood flow to the vagina, resulting in transudation of plasma, which results in vaginal lubrication. And then the pudendal nerve is involved by providing sensation to the clitoris and also maintaining contraction of the perineal muscles, which maintains the female erection. Both the pelvic nerves and the pudendal nerves are thought to be involved with the rhythmic vaginal and uterine contractions that are associated with orgasm. So also important there. If you look at the anatomy and where these pelvic nerves actually run, you can see that they come down and they go right along the dorsolateral wall of the vagina. And therefore, when you do a radical cystectomy, it's quite easy to injure this nerve plexus, which may contribute to sexual dysfunction. Additionally, in terms of blood supply, which is not only important for the female erection, but also because devascularization of the clitoris can result in replacement of the smooth muscle with fibrous connective tissue. You can see here that the blood vessels actually run right along the base of the bladder, right next to the urethra, so are quite easily injured at time of radical cystectomy. Therefore, Dar in 2007 suggested a way to do a nerve-sparing cystectomy. And you can see it in this image here. So this back here is the rectum, this is the vagina, this is the bladder. And this patient has a bladder tumor on the left side here. Therefore, they recommend taking the pedicle as posteriorly as possible to preserve the margin. However, on the side where there's no bladder tumor, they recommend that in order to nerve spare, you actually take the bladder pedicle closer to the bladder to spare, I guess, all of these nerves that run along the lateral wall of the vagina. And then they also recommended transecting the urethra immediately distal to the bladder neck with minimal dissection in the area to try to preserve the blood supply. The actual evidence for the effect that nerve-sparing cystectomy has on women is poor. Zaran, in their systematic review in 2016 that looked at sexual dysfunction, found that the incidence of sexual dysfunction might actually decrease to 10% from 59%. However, this was in a group of 30 patients, and they also included patients who received genital-sparing cystectomy, not just nerve-sparing cystectomy. In 2006, there's another study published that looked at the female sexual function index, shown here, and they found that in their 13 nerve-sparing patients, their score from preoperatively to postoperatively didn't decline much when you compare the pre-op to post-op score for the 7 non-nerve-sparing patients. And then there should also be a theoretical improvement in urinary function, just because you're sparing innervation to the sphincter. The evidence for actually undergoing organ-preserving radical cystectomy rather than just nerve-sparing is slightly better, but also poor. So in 2017, a systematic review of 15 studies and 870 women was published. This showed that in terms of sexual function, and there are 7 studies with 2 comparative studies, satisfaction was overall high, with 86% of nerve-sparing patients resuming sexual activity within 6 months. And then in the 2 comparative studies that were included, organ sparing had better scores on the female sexual function index than conventional cystectomies did. This systematic review also looked at continence rates. So theoretically, for organ sparing, day and nighttime continence should be better because you're preserving the nerves to the sphincter, and self-catheterization rates should be lower because by preserving or by sparing the other pelvic organs, you provide a back to the neobladder and you prevent descent of the neobladder into the pelvis, which can result in I guess requiring self-catheterization, so urinary retention. But they found that the rates that in the nerve sparing, vaginal sparing, and genital sparing compared to non-sparing down here were actually super disappointing. There was no significant difference between groups. And then finally, they also looked at oncological outcomes, so both 5-year cancer-specific and 5-year overall survival, and found that for organ sparing, the rates were 70 to 88% compared to 66% with the conventional radical cystectomy. Similar for overall survival, and then recurrence rates were also similar between the two groups. However, it's important to realize that for these patients, the inclusion criteria were usually quite strict. So all patients in the organ sparing group had negative bladder neck biopsies. They had good baseline functional status. If they did have tumor at the trigone or bladder neck, or any tumor that might be in contact with the vagina on cystoscopy or bimanual examination, they were excluded. And so it was usually patients with low disease severity. Therefore, this study that came out in 2022 is interesting because they actually included patients that had T3, T4 disease. So they looked at 289 women, 188 of which received organ-sparing radical cystectomy, and compared outcomes. Again, you can see that in the organ-sparing group here, patients had significantly lower T-stage and significantly lower end-stage. However, when a multivariable analysis was done for overall survival, the only risk factor was T-stage and not organ-sparing radical cystectomy. In their tables of looking at overall survival, cancer-specific survival, and recurrence-free survival, there was again no statistical differences between survival, although theoretically there is a large selection bias for organ-sparing patients to be younger and healthier, and therefore you would almost expect them to have better cancer-specific and overall survival. So in 2018, Abulova's group tried to come up with a list of indications for organ-sparing radical cystectomy. They suggested that young patients age 55 or younger with good performance status, premenopausal, and good preoperative sexual function should be included, or at least considered, because this will maximize continence and sexual function. Patients who have CIS tumor at the bladder neck or trigone and more than T2 cancer should be excluded to minimize oncological risk. And then it's important only to include patients who do have the manual dexterity to catheterize in case they go into retention. The last thing to consider during a radical cystectomy where you're doing organ sparing is whether or not to do an oophorectomy. The advantages are obviously it eliminates both the risk of having bladder cancer involvement of the ovaries as well as the risk of developing ovarian cancer, which has the highest mortality of all gynecological cancers and is the 5th leading cause of death or cancer death among women, and for which screening is really not very feasible. Additionally, an oophorectomy is related with decreased risk of bladder cancer. However, recent studies have shown that there's actually an increased risk of mortality, cardiac disease, stroke, osteoporosis, hip fracture, and cognitive impairment in females who undergo bilateral oophorectomy. They also have to deal with the symptoms of menopause if they're premenopausal, and it can result in increased risk of sexual dysfunction postoperatively. So the American College of Obstetricians and Gynecologists actually recently changed their guidelines so that they now say that routine prophylactic bilateral oophorectomy for prevention of ovarian cancer is no longer recommended. And this is in the context of hysterectomy. This is partially due to the fact that recent studies have been pretty compelling in showing that ovarian cancer the origin of ovarian cancer is the fallopian tube rather than the ovaries themselves. So in 2001, a group looked at the specimens of 12 patients who underwent prophylactic BSO for BRCA mutations, and they found that out of these 12 patients, 6 of them had cellular dysplasia and 5 of them had hyperplastic lesions in the tubal epithelium. All of these lesions resembled high-grade serous ovarian cancer, suggesting that the origin might be the fallopian tube. So in 2007, a second study was done looking at 55 patients who had advanced stage serous ovarian cancer, and they found that 75% of these patients had tubal intraepithelial carcinoma, or TIC. And then when they examined the exact mutations present in the TIC versus the metastatic disease, they found that they had the same mutations and therefore were likely clones. In 2012, the histology of 29 patients was examined, and all of these patients had TIC and high-grade serous tumor. Here, 93% had identical mutations in the TIC and the serous tumor, and therefore they concluded that the TIC was a precursor lesion of the metastatic tumor. And then this image here was made from these results. It shows in the middle here the origin of the ovarian cancer, and you can see in the purple, it's thought that the majority of ovarian cancer now comes from the fallopian tube epithelium, with a small proportion actually coming from endometriosis. And there's really almost none that comes from the ovary directly. And then the important part here is that high-grade serous cancer is thought to essentially all come from the fallopian tube epithelium, and that this comprises all of the type 2 cancer. In this case, type 2 essentially means that these are the patients who have more aggressive cancer with worse prognosis compared to the type 1 patients. In terms of risks of oophorectomy, a Nurses' Health study looked at 16,000 patients who underwent a hysterectomy with bilateral oophorectomy and compared this to 13,000 patients who underwent hysterectomy with ovarian conservation. As expected, the patients who had both of their ovaries removed had no cases of ovarian cancer, regardless of age. However, if you look at the incidence of stroke, cardiac disease, and all-cause mortality, the patients who did have both ovaries removed had significantly higher risk of all 3 of these in the study. And in fact, they concluded that with an approximate 35-year lifespan following surgery, 1 additional death is expected for every 9 oophorectomies performed. So quite an increased risk of all-cause mortality. Therefore, the ACOG actually now suggests that a prophylactic bilateral salpingectomy with ovarian preservation be done at time of hysterectomy instead of bilateral oophorectomy alone. This is a study done in 2022 by a local group, and one of the first studies that actually looks at the outcomes of undergoing salpingectomy for ovarian cancer prevention. They looked at 25,000 patients who underwent opportunistic salpingectomy at time of hysterectomy and compared this to 32,000 patients who just had a hysterectomy. They found that the rate of serous cancer was 15 in their control group and 0 in the salpingectomy group. In terms of epithelial cancer, there were 21 in the control group and less than 5 in the salpingectomy group. And then they made these tables as well, where they calculated the expected number of cases in the salpingectomy group based off of the control group in order to control for follow-up time, patient age, etc. And again, there is significantly fewer cases in the observed group compared to the expected group. So they concluded that doing a salpingectomy does decrease the risk of ovarian cancer. It's also important if we're talking about radical cystectomies that there's no bladder cancer involvement of the ovaries. In 2012, Salem did a study of 360 cases and found that none of the patients had bladder cancer involvement of the ovaries. In the study, 29 patients had their ovaries preserved, and in these patients, 0 had recurrence within the ovaries. And they did a bit of a literature review as well and stated that this corresponds well to what the numbers in literature are. Taylor in 2019 looked at 123 cases and actually found that 4% of these had bladder cancer that involved the ovaries. If we look at the 5 patients down here that did have bladder cancer involvement of the ovaries, you can see that all of them had lymphovascular invasion. All of them had T3 or T4 disease. 3 out of the 5 had positive margins, and then the majority of them actually had variant histology as well. And so Taylor concluded that ovary-sparing cystectomy is likely safe in women with organ-confined disease. So in summary, there are significant gender disparities in bladder cancer outcomes, as well as treatments between men and women. Women are less likely to receive a neobladder, even though it is a good option in well-selected patients with a low risk of urethral recurrence and continence rates of around 80%, with hypercontinence rates of around 15%. Organ-sparing cystectomy is also an option for patients, which may improve urinary and sexual function, but the evidence overall is poor, so further studies should be done to examine both the safety and the efficacy. And then given this new evidence about the origin of ovarian cancer and the risks associated with oophorectomy, an ovary-sparing cystectomy should be considered. Any questions?